Thank you for joining us for this first ever NHMRC webinar. I'm going to talk for about 30 minutes or so. You can send questions in during that time, or you can wait until the end, and we have folk here on my right, here in the offices of NHMRC in Canberra, who will help me see those questions, and we'll try and answer them. I should start off by acknowledging the traditional owners of the land wherever you are around Australia, and in a spirit of reconciliation offer my respects to elders past and present. In previous years I've tried to visit each major city to present the outcomes of the funding round of the year. So this year we're trying something different, doing it via the web. And also, before I start, I should thank all of you who have contributed to our peer review process this year, the many thousands of people who have done so. Peer review is the only way we can make decisions about what to fund at the NHMRC, and so your help is absolutely essential. In health, research and evidence is as important, probably more important than it's ever been before. If we want to help our patients, if we want to have the best system we can, we need to base it on science and on evidence. There's so much more to learn, and I don't need to tell you that. For example, recent advances in genomics, in epigenetics, in the neurosciences, in advanced modelling of systems, in informatics, give us a glimpse of what the future holds. And on the other hand, we know there's this very large gap between what we know and what we do in the health system, a gap between evidence and what happens in practice and in policy. So thinking about our role, we encapsulate it really in four words: create, translate and build capacity. And I'll talk a little bit more about that in a moment. Before I go into some slides which describe what's happened, if there were more time, I'd talk about some other things. For example, our next strategic plan will go to Parliament very shortly. The research translation faculty, over 2,500 researchers helping NHMRC directly. Conflicts of interest, particularly working with the private sector, not around research and peer review especially, but more generally. The implications of modern genomics for our health system, and we're working on a number of environmental issues such as lead contamination, asbestos, and the possible ill effects of new technologies, for example, some of the concerns around wind farms. But let me now go on to the slides, and I'll talk you through each of them. I'm going to go fairly quickly, but you'll be able to do them at your own pace. This first slide gives you an idea of the extent of support that we give. This isn't all our funding schemes, but gives you an idea of the number of grants that will be administered by us and what you will work on in the research sector over 2013. I'm going to mention most of those in a minute, but I'm not going to mention partnership projects for better health. That's a big topic in itself. Currently, we have over 200 partner organisations partnering with the NHMRC in supporting implementation research generally, and this is an area which we encourage more applications in. 88 universities and medical research institutes and other organisations administer those grants, will be administering those grants next year. But it has a much larger net than that. If you look at the slide, the grants go to be administered somewhere, but the researchers are spread in over 300 different bodies, organisations, institutions around the country, including, as you see, more than 100 hospitals. This slide shows the announcement that Minister Plibersek made in Sydney on the 19th of October. The key points on this slide really are that our biggest single investment, as you know, is in project grants, and I'll spend a bit of time talking about project grants in a moment. The next big investment is build capacity. So project grants are create knowledge, build capacity are our fellowship schemes, and many other ways as well. And again, the dollar amounts are there, and I'll talk a little bit about them in the future. I often get asked about what is our investment in the major areas of burden of disease for Australia. And these are the formal national health priority areas that have been agreed between the state and Commonwealth governments. There are 9 of them now, with dementia recently being added. And as the slide shows, about 60% of our grants go to these 9 areas, 9 health priority areas at the moment. Of course, they vary a lot. So some of them are at the cutting edge biomedical science, for example, in cancer or cardiovascular disease. But there are grants also in clinical research, health services research, and public health research. I've emphasised that our strategy is create, translate, build capacity. So if you look at the virtuous cycle on the right-hand side of your screen, the taxpayer of Australia, the community, provides money to medical research through their government to create knowledge through us and through other government-funded bodies, but today through the National Health and Medical Research Council. That's what we do and what you do if you're a researcher. But of course, why the money is provided are the green boxes up the top there, because what the people of Australia hope, and you know this as well as I do, that they hope that they'll be healthier through better prevention based on research evidence of what works, that they'll be provided better care through better treatments and a system based strongly on evidence, and that we contribute to national prosperity in the future through innovative industry growth as well. So the dot points on that slide are some of the key funding schemes we have, which are all targeted towards that overall strategy. Now the next 7 or 8 slides are around project grants, and starting off with this year. 3,700 applications received, including some where people are seeking us to do the peer review for the Cancer Councils and the Heart Foundation. This is a way that we're trying to reduce the overall peer review load in Australia by doing it on behalf of other charitable funders. We eventually had enough money to fund 731 grants, and that rounded to a half decimal point is a success rate of 20.5%. The key work, of course, done by the thousands of external assessors and the 36 GRP and their members, and again, as the last couple of years with independent chairs of those panels. If you're interested in more detail of what we do in project grants and why we do it, then I wrote a little opinion piece about this, I suppose, earlier in the year, and on that slide there is the links to it. But if you go to our website and search for CEO and peer review, you'll find it. This slide shows the 4 what we call research pillars, and that is basic science, clinical science, health services research and public health research. And it includes the numbers of applications in each of those categories, the numbers funded, and the funded rate in each of those over the last 3 years. So the grey bit on the right-hand side is this year, and these are grants just to the NHMRC, so not including those to Cancer and to Heart Foundation, Cancer Council. And the funded rate on the right side. Of course, these funded rates are entirely determined by the GRPs and how they rate every single project grant on a common set of criteria, 3, scientific merit, relevance or innovation, or record of achievement or track record. And so there aren't pre-set success rates, they are just what comes through the system. This is the history of the project grant scheme, and some of you may have seen this before, but you won't have seen this last bar, which we've added for this year's funding round. The top of the bar shows the total numbers of applications since 2000, and as you can see, there's been a very, very large increase over that period of time. The lump in 2006 is where we asked for notice of intents first, which seems to encourage more applications. Now, the green at the bottom are the numbers of grants that were able to be funded with the available finances each year. And as I've said before, and now rounded to the digital, no decimal points, so 21%, 20.5% success rate this year. The key point on this slide in many ways is the blue middle part of the bar. So these represent applications which are GRP considered worthy of funding, but which weren't able to be funded because the money ran out funding the green ones at the bottom. So as you can see, around about 50% of all applications, our GRPs feel are worth funding. There are 4 or 5. They're assessed as worth funding, but there's no funds to do so. And so you'll be hearing me talking about funded rates rather than success rates. And the reason I shy away from success rates is that it tends to indicate that the application was, not such good science if it wasn't successful. Of course, these are 5s and 4s, and they are good science. You're unsuccessful in getting funds, but in terms of ideas and the views of your peer reviewers, these are worth funding. Now, as you saw in that previous slide, the success rate has been pretty standard over recent years, between about the high and the low 20%, despite, as you'll see, quite a large increase in funding here. And there are a couple of reasons. The first was on the previous slide. The number of applications is soaring and continuing to soar. And the second side is the average grant size has increased. This is the average grant size since 2004. And if you look at the top bar, which are grants beginning next year, so 2013, this year's funding round and beginning next year, you'll see that there's a bit of an increase over last year. And every time the grants get bigger, the numbers that we can fund, of course, get smaller. So this is the increase in funding, and this may come as a surprise to you because the success rates are pretty much the same, yet we're putting in nearly $300 million into project grants compared to 2004. And so that's the success rate. The funded rate doesn't change very much because the average grant size goes up and the numbers of applications goes up. This slide emphasises that each year we try and support new investigators in the system. So these are people getting their first NHMRC or other major funding body grant. Each year we deliberately fund around about 7 or 8% of all applications for people who are applying for the first time. And so the top bar shows you that. There were 54 people who got their first major grant, NHMRC grant this year out of the total of 731. This is a policy NHMRC has had for at least 30 years and I think does allow some turnover of applications and allows applicants and allows new people to have a go in the system. Whenever I did this talk by going around the states and territories, of course, each state or territory wanted to see how well it had done and usually think that there's some problem that relates specifically to their state or territory. Of course, we don't have quotas on a geographical basis. This is just what comes out of the peer review system for project grants. I've shown here the last 3 years. Some of the smaller states bounce up and down a little bit in terms of funded rates. However, as you see, each year the most applications come from Victoria and partly as a result of that the most funded grants are usually Victorian as well. And a couple of the smaller states we've been around as senior officials at NHMRC to talk about how they could perhaps develop the capacity of the research community in those states. This year, so the one starting next year, 76 different institutions put grants into us, or from researchers through 76 institutions, 37 universities and 39 MRIs and other institutions. Of those 76, 34 of those institutions received no funded grants. They weren't in the top 20.5% of all applicants, and another 11 received fewer than 3. So you'll see that, and I'll show you that in a moment, that the majority of applications are won by the larger organisations, and a very large number of organisations each year, varies a bit, but receive a few successful applications. Most applications to the NHMRC come through universities and then medical research institutes. The colours of the bar represent whether they're applications in the 4 pillars, basic clinical health services, public health research. You'll see there's a little bit of difference in the ratio. It's about equal basic and clinical for universities, whereas the institutes are a bit more in proportion basic. Now that's who administered it, but this is where the research occurs. And these figures are a little old, they're 2006 to 2009, but we are in the process of updating those now. The big change on this slide versus the previous one is hospitals. As you see, 16% then of research administered mainly by universities actually occurs in hospital, and another 3.8% in a government body of some sort, usually a state health department. So, so around 20% or so actually happens out in the health system. And the medical research institutes also administer, conduct grants that are administered elsewhere. So this picture comes out mainly of the fact that there are no indirect costs of research support for hospital-based research, and it's something that we've been arguing about and supporting for quite a while here at the NHMRC. This is this year's project grant rank order, if you want to think of it that way, for project grants. Remember, this is all competitive, so it's how it works out. I think there are 23 of the 35 or so funded institutions on this slide. You'll see that even those top 23, quite a lot receive less than $10 million overall. And the majority of funding is won by the group of 7 universities and the big 5 or 6 medical research institutes. Excuse me. So that's all I'm going to say about project grants. In the next couple of days, we'll be putting even more data on our website. Programs, these of course really perhaps should be better called team collaborative grants. They're all for 5 years. And just a reminder that project grants can be for 5 years should people wish to apply for that. They can be for any length at all, actually, up to 5 years. Since 2003, we've had just over 200 applications and 121 of those funded. They're primarily in basic science and clinical medicine, although there have been some in public health research. No applications in health services research the last 3 years, and so we think that our partnerships for better health projects and centres is probably better suited for health services research. It's the usual suspects here in terms of application numbers and success in granting. Again, the group of 8 and the larger medical research institutes. Development grants. This is about 10 or 12 years old, this funding scheme. They're grants just for early proof of principle or seed stage research. We can only fund research out of the MREA and not commercialisation. We've had over 800 applications since 2003 and over 200 funded. We've just commissioned an independent assessment of these. The group that did it at arm's length from us selected 40 grants and looked at what had been the outcome, and we will release this on the 23rd of November because we have a special innovation round table in Melbourne on that date. Just perhaps point to the bottom two slash points there, that of those, a full 55% are currently under some form of commercial development, and 6 have already resulted in a product to market or are awaiting regulatory approval. So really pretty happy with that outcome, although the review has suggested some further changes which we'll discuss with NHMRC's Research Committee. One of the things about development grants is perhaps you don't have the usual suspects there. Yes, big institutes and universities are very prominent, but some of the other universities here have put lots of applications in and had quite a number of grants. University of Wollongong, University of South Australia, and the Centre for Eye Research, for example. So it's a slightly different mix than the competitive project grant scheme. I'm not going to say much about Centres of Excellence. This is some stats for you for the last 3 years. I would like to make the point that we now have 3 streams: a clinical stream, a health services research stream, and a population health stream. The latter two have been running now for 5 years or so, and they replace the previous capacity building grants in those areas. They're still focused really on capacity building. There's a lot of interest in this scheme, and we have a fantastic group of centres of research excellence in just about every area you can think of, scattered across the country. So now moving towards the end now about people support schemes, starting with early career fellows, and this slide shows again the last 3 years and the 4 pillars. The success rate here is one of the highest ones, I suppose, running high 20s or 30%, and that's a strategic decision to make sure we give people that first break into the system, and we have strong applicants from all the 4 pillars, although as usual more from basic science than other areas. The next lot of fellowships, career development fellowships. Lots of people point out that career development is probably not quite the right word, because these are really outstanding people already, and we had some discussion about that at Research Committee last week. But again, these are the 3 last years. As it says on the slide there, over 2,500 applications received since 2003 and nearly 500 funded. For quite a while there, we were worried that people were putting in highly uncompetitive applications. They're spending quite a lot of time preparing an application with little hope of being funded. So there's a web address at the bottom of that slide that describes the sort of level of achievement the successful applicants get, which is a bit stunning actually, and if you are a supervisor or advising somebody about application, it's worth having a look at that to see whether they're in the ballpark as terms of competition. Now the NHMRC's research fellowships, we usually say prestigious research fellowship and we mean it. This is a scheme that is, of course, highly competitive. Some of the best in Australia, full-time research on NHMRC research fellowships, and now across all the 4 pillars as well. That's been a change over the last 10 years or so. Still predominantly applicants from biomedical sciences. The success rates there look a bit misleading in a sense, because this is incredibly competitive application process. Most people who had a 5-year fellowship reapply, apply for appointment again as a fellow, and they were terrific in the first place to be selected, and they've been full-time research, so they remain highly competitive. But each year, around about 1/3 or so of the successful applicants are new new people. People don't have a current fellowship out of the CDF program or off a Heart Foundation fellowship or coming back from overseas or so on. But I do want to make the point that that is a small number, and so one of the things that's been on our minds and research committee's mind about this is what's the right number ratio between CDF's career development fellowships and research fellowships, because setting people up with nowhere to go after a mid-career fellowship is probably not a kind thing to do. So that's the People Support Scheme. Just a couple of final slides on some additional matters. In recent times, we've been developing what the Americans call RFAs, and which we call targeted calls for research. We have some strict criteria. For example, it has to be something relevant to Australia rather than, you know, just more great research in whatever area it is. It has to align with our strategic plan. And it's got to be clear that what's needed to be done is not, some of our existing schemes don't really cover it, so you need a special call. Recent examples are down the bottom, the one with A-Star, which is just completing, a recent one with Hendra, and this one on prevention of mental illness in children of last year. But really our priority number one, and when I say this every time, I think wouldn't it be great if we'd actually achieve more from the research. The research is great, but our Aboriginal and Torres Strait Islander people still suffer disproportionately from ill health. But we are committed to at least 5% of our funding for Indigenous health research of direct relevance to Indigenous people. And you'll see from the pinkish sort of coloured bars there that the amount has been increasing over that period of time, and the dotted line is the proportion. So we're over our targeted 5% at the moment. I've been very keen to make sure that we participate more strongly in international research since I've been here. And if you're interested, in the 18th of October issue of Nature, there's a couple of fantastic articles about globalisation, really, and as the future in research. Also makes the point that Australia is near the top of the list in terms of collaboration already. So our research community is very capable and very collaborative, I think, by instinct. So here are some of the big initiatives and collaborative funding activities that we have. Very proud of the people we fund through the International Cancer Genome Consortium with their recent signal paper in Nature Med, and the Global Alliance for Chronic Disease, which funded implementation research in community control of blood pressure, is rolling on, and we are going to decide what is the next priority for that global alliance, which is us, NIH, Canadian Institutes of Health Research, China, India, South Africa and the UK. And then finally, on the Human Frontier Science program, we pay the subscriptions for that each year. Over the last, 6 years, we've spent $5 million on that, and Australians have won $12 million back. So that's not a bad investment of your money and ours. 3 forum and workshop I just wanted to mention. We've just finished our H5N1 forum. This was with the Bill and Melinda Gates Foundation. We had Yoshi Kawaoka here. He was one of the authors of paper that pointed out that the H5N1 mutations could very quickly lead to human-to-human transmission, which is a very scary prospect. So we've got some ideas and plans forward of how to support research in this area from an international perspective. We're going to have a commercialisation innovation workshop in about 2 weeks' time, I think, down in Melbourne, and will build on the development grants that we've done so far and think about what we, but especially others, need to do, really, to make sure that we capture the benefits out of health and medical research. And then early next year, we're having an international review, symposium on peer review. We are going to focus on 2 particular things. some principles of peer review, because I think we need a stronger shared view on what it is that we're trying to do in peer review. There's been a lot of discussion even today about one of the aspects of it, but there are many issues, and remember always this is the taxpayers' money and they want to make sure that as much attention as possible is paid to this. And then the second thing we'll be concentrating on is some ideas we have to streamline peer review, and we'll have a discussion paper ready for that, and then a wider discussion with the research community. As it says on the slide, we have our international colleagues at NIH, Canada and the UK coming and talking about what they're thinking about and where they're up to, and again, some more international collaboration. I mentioned the research translation faculty at the beginning briefly. Now over 2,500 of you have agreed to help us develop cases for action so that our council can work out where the real opportunities are to plug that gap between what we know from research and what actually happens out there in policy and practice. And one possibility will be for development of a targeted call for research, some transformative research that's needed to fill that gap. Clinical trials, there's a lot of discussion over recent years about the difficulty of multi-centre clinical trials. We've now completed our work on that to produce this national approach to single ethics review. And if you go to our portal, you can find everything you need for that to happen. I'm not sure that we're doing as well as we could in this area as a country, because of course the second part, ethics is only the first part, the second part is to make sure that all the issues around governance and responsibility are addressed at the hospital or the local site. Now again, we have some material on our website to help hospitals and institutions address this, and I hope that that will help in the future. Also mentioned the Australian Clinical Trials website. This is the first step. It'll undergo quite a lot of development over the next year or so, and as it says there, there's a lot of information, and it's especially designed to help industry and consumers, I guess, see what's going on in a more holistic sort of way. This is the last slide. You'll know as well as I do that there are lots of challenges that we face. For you, if you're a researcher, obtaining continuing support for your research is probably top of your agenda. But here are some of the others that I'm sure many of you will share with me. The first one, and this is really identified in the draft summary that the McKeon Committee has released. How do we make sure that science and evidence from research is more embedded into the health system? There is no simple answer to that, but we all want it to happen so that we've got better patient care and prevention, and indeed cost-effective care, so we're not spending money on things that research has shown to be not worthwhile. Many of the health issues it faces are big issues, what some people call wicked issues. I'm not sure I'm all that keen on that particular expression, but they're going to require continuing changes in how we address things. So collaboration, making sure we don't put barriers to collaboration. We're going to need new discipline, we're going to need modelling, we're going to need the behavioural sciences. They need multidisciplinary and indeed new disciplinary approaches. We'll have to work globally, as I've mentioned, and we have a particular issue, I think, around national facilities to underlie research. And I believe that the NCRIS roadmap is still a great document that does identify the key initiatives that are required there. The next two dot points are really about the environments in which you work, your institutes, your universities, your hospital, and so on. We need to be all, and the NHMRC included, turning our thoughts to how best ensure that institutions can support you and other researchers around the country. Some of that is to do with just making sure there are the facilities and the collaboration and the supportive environment there. How do we attract and retrain? Maybe attract at the moment because other countries are facing more financial problems than we are. A balance between people right across the spectrum, clinical researchers, health service researchers, biomedical researchers of all types. Other career options, many people have said, wouldn't it be great if more of our business leaders and our politicians and community leaders were research trained and could bring the skills that we all learn as researchers to those jobs. And the next point is something we're working on here with some vigour, I suppose, and that is how do we combine, how do we help people who want to have a family, want to engage with their family and combine a research career. These will mainly be women for the next little while, the way our society is set up. So how do we become more family friendly? How do we support those women who have kids and can't work full time? So we've got an expert group of women and a couple of blokes on to try and come up with some ideas, and of course, as ever, we will consult with you. The integrity research, our trust by the community and therefore our support relies on us being vigilant about integrity in research. This is something that's all our responsibility, to make sure that that we don't lose the trust of the public because we don't have the highest standards in truth and honesty in our research. And then those final 2 points, I return to this issue of our support comes from the community. So if the community pays for the research, in a sense they own the outcomes of the research. Most of you will be aware that we've recently introduced a policy of open access to publications of NHMRC funded research. Will become fully in place halfway through 2013. But some of the data is also, of course, paid for by the taxpayer and the community, and so we're working on an international scale with how we develop up protocols and so on around that. And then finally, this is done on behalf of the people in our community. There's no doubt that there's a strong move that's been growing now for 15 years or so for stronger involvement of participants in research, of the community more general. I think in Australia we have some great examples where that works well, and we have great community support of research through charitable funding bodies, but we can always do more, and NHMRC will release our updated draft guideline for community consumer engagement research in coming weeks. So thanks for listening to all that. We will put a broader set of slides on the website over the next few days so that it has more detail than that.